Well, I do see that it's 2 p.m. So to respect everyone's time, I'd like to get started. Good afternoon and welcome to the NIH Religion, Spirituality, and Health Scientific Interest Group's first webinar of the year. So Happy New Year. We are so glad you are here for what promises to be a very interesting and informative presentation. My name is Joan Romaine, and I am the founder and chair of this group, which began here at the NIH in October of 2020. Today, it is my great pleasure and honor to introduce our guest speaker, the Reverend Dr. Q English, who is the director of the Center for Faith-Based and Neighborhood Partnerships at the U.S. Department of Health and Human Services. And she works closely with the White House Office of Faith-Based and Neighborhood Partnerships. The HHS Center's core focus areas include addressing COVID-19, maternal health, mental health in youth, suicide prevention, and substance use disorder, inclusive of overdose prevention. Working with the operating divisions housed within HHS, like the Center for Disease and Prevention Control, Centers for Disease and Prevention Control, the CDC, and Substance Abuse and Mental Health Services Administration, SAMHSA, and the Administration for Children and Families, ACF, Reverend Dr. English and the Center seek to address the priorities identified by the Biden-Harris administration. Reverend Dr. Q English received her master and doctorate degrees from the New York Theological Seminary, where she was the recipient of the Excellence in Ministry Award, the highest award given to a graduating doctoral student. Before I turn it over to Reverend Q, I would like to ask that everyone please stay muted with your videos off unless you are speaking. Obviously, at the end, when we have a discussion, we would like to invite everyone to keep their videos on so we can kind of get to know each other a little bit. So at this point, and just as you've noticed, we are recording, just want to make mention of that. If you have questions, please put them in the chat. And at the end, you can also raise your hand for questions, and we'll try to get to as many questions as possible. So, Reverend Q, please take it away. Thank you.
Thank you so much, Joan, and thank you to the Religion, Spirituality, and Health Scientific Interest Group at NIH for inviting me to participate in your ongoing conversations. So we at the HHS Center are so pleased that this group exists, as it encourages increased attention at NIH and in the research community on how religion, spirituality, and the participation of faith communities have important impacts and considerations for health and well-being. Next. Since 2001, the Center for Faith-Based and Neighborhood Partnerships at the United States Department of Health and Human Services, or as we like to call ourselves, just the HSS Partnership Center, has served as the department's liaison to the faith community and to grassroots organizations. So we exist to engage, communicate, and collaborate with these organizations, ensuring that local institutions, which hold community trust, have up-to-date information regarding health and human services and activities and resources in their area. And through the center, as you heard, we focus on key administration priorities that align with faith and community leaders' interests and strengths. They include maternal health, especially as it is experienced in populations with increased disparities. This focus area is critical as the United States has the highest maternal mortality rate than any developed nation in the world, with African American women 3 to 4 times more likely to die from pregnancy-related deaths than white women, and American Indian, Alaska Native women 2 times more likely. To that end, in support of the White House blueprint for addressing the maternal health crisis, the HHS Partnership Center launched the Moms Tour, engaging in a department-wide multi-agency maternal health engagement strategy with the overarching goal of making the U.S. one of the safest nations in the world for women to give birth, regardless of race, ethnicity, geography, or other factors. And through this public-private partnership, Mom's Tour events have served over 5,000 mothers and families in 2023, connecting them with vital services and resources in their local community, provided by more than 240 organizations that I call the Village, in an effort to improve maternal health outcomes in our nation. These connections included mental health care, substance use disorder support, information, and thank you, NIH, doulas and midwifery services, healthcare coverage, and more. Our next focus area is on mental health, including youth mental health. Then suicide prevention, with special emphasis on youth suicide prevention, substance use disorder, and last but not least, strengthening public health response and ongoing work to increase awareness about COVID-19 and now RSV and flu. In support of these focus areas, the Partnership Center has produced several toolkits and guides for faith and community. We have a substance use disorder toolkit, our youth mental health toolkit, maternal health guide, and a suicide prevention guide for youth in partnership with SAMHSA and the National Action Alliance for Suicide Prevention. These are readily available on our website, and our maternal health guide will be available shortly. So within these efforts and extending beyond them, the Partnership Center works in collaboration with any and all of the 27 offices and agencies that make up HHS to extend the reach of and impact of HHS-related programs into communities. And that work includes working alongside HSS to prevent human trafficking, address chronic health conditions, HIV/AIDS prevention, increased immunizations, and many of the other issues those 27 offices and agencies address. Next. And we do this work because of the amazing and diverse range of services, efforts, and programs provided through people of faith in every community in the United States. So I'm excited to share just a sample of some of those efforts with you today. And as part of those remarks, I want to draw your attention to the diversity of faith traditions, organizations, and structures, as well as the different areas that these groups are focusing their efforts. First, our individual houses of worship. So oftentimes when we think faith-based, we think of bricks and mortar houses of worship. We think of large ministries as seen on TV and how they may be large-scale trusted messengers. However, any house of worship or gathering of people of faith offer a wide variety of ways they can impact the community. So economically speaking, a study by the Partner for Sacred Places found that the economic impact of the average urban house of worship is $1.7 million annually. It is also reported that they have staff that work in the community and in the house of worship. Houses of worship employ 5 full-time and 6 part-time staff on average, according to the report. Houses of worship can be a magnet for visitors, attracting 780 visits each week, with only 11% of visit for worship and 89% of visits for other purposes has been reported. Houses of worship also serve their community. 87% of the beneficiaries of the community programs and events housed in sacred places are not members of the religious congregation. So their touch can be meaningful and their reach vast, especially in our experiences as it relates to the health and well-being of the community. For instance, Enon Tabernacle Baptist Church in Philadelphia. I'm sorry, we can do next. Kept going and forgot to mention that important word of next. You can go up one, please. Thank you. For example, as you see there, Enon Tabernacle has been doing great work in their community. They recognized this challenge and they decided to do something about it. They hold maternal health events and now recruit and train doulas to provide culturally competent maternal health services in their community. In fact, they have now started to work with our office to train doulas in cities partnering on the Moms Tour. To date, they have certified over 40 doulas, now offering great support for pregnant and postpartum moms within their house of worship, as well as within the community. Individual houses of worship are important and critical, but they are only one of many efforts we can consider when we think about faith-based programs and initiatives. Next. It is also important to consider that many or most houses of worship are part of robust networks of members of their tradition, regionally, nationally, and even globally. Community partners, ministerial alliances, or interfaith and/or multi-faith efforts. These connections and collaborations help community leaders work together to effect greater change that they can on their own. One such effort that has been underway for more than a decade is Hope Ministries program, coordinated through the traditionally African American Christian tradition known as National Baptist Convention USA, Incorporated, led by Dr. Jerry Young. Hope Ministries is led by Reverend Dr. Michael Miner and is a collaborative effort of National Baptist churches, medical professionals, and health-related organizations committed to health outreach and prevention education. And while the ministry has a number of different components, let me focus on two that have interacted with Health and Human Services specifically. So with the passage of the Affordable Care Act, partners were needed to encourage consumers in hard-to-reach and diverse populations to consider the health insurance options available to them. Partners in these roles were federally funded partners known as navigators. National Baptist Conventions was an early navigator sub-grantee and is now one of the leading experts on increasing awareness and enrollment throughout their network and the state of Mississippi. But they did not just stop there. Hope Ministries has also been a partner in the All of Us campaign, which is coordinated through NIH to build one of the largest biomedical data resources of its kind, with a specific focus on diversity within this data set. And alongside other diverse partners, NBC USA Incorporated has established best practices for encouraging its members and others in their communities to participate in programs so that more African American individuals can be part of the precision medicine movement. Next. Now, as we look beyond houses of worship and networks of houses of worship, there are also people of faith who coordinate their efforts through robust, established nonprofits that affiliate with a faith tradition that informs their mission to serve their communities, such as Catholic Charities, Islamic Relief, Convoy of Hope, and Lutheran Services in America. Some groups remain in close coordination with their religious founding, and is especially prevalent for people from the Jewish tradition who organize their efforts through social service entities that are separate from their physical house of worship. One such effort is Upstreet Pittsburgh. Upstreet is a brief intervention service for youth provided through the Jewish Family and Community Services, also known as JFCS, in Pittsburgh, Pennsylvania. Upstreet offers drop-in consultations with therapists, scheduled therapy appointments, text-based peer support, and support groups for teens. So teens can talk about whatever's on their mind and they don't have to worry about scheduling an appointment or committing to a long-term therapy relationship. And while this mental health initiative is celebrated for its innovative and dynamic approach to youth mental well-being, JFCS continues to be a leader in Pittsburgh as it serves refugees, seniors, and other vulnerable population with evidence-based practices and services. There is also there are also efforts coordinated through academic institutions that build the capacity of faith communities to address challenges. These programs leverage the resources of the academy and often translate evidence-based models into the context of diverse faith communities and partners. One such program is the Stanford Muslim Mental Health and Islamic Psychology Lab at Stanford University, run by Dr. Rania Awad. The Muslim Mental Health Lab serves as an academic home for the study of mental health and psychology in the context of the Islamic faith and Muslim population. They also conduct extensive research into understanding Muslims' unique needs pertaining to mental health and the Islamic faith, and aim to tackle the stigma surrounding the Muslim community regarding seeking mental health services and the association between mental health and spirituality. You might not know that Muslim Americans are more than 2 times more likely to attempt suicide than Protestant Americans, and are more likely to attempt suicide compared to Muslims living in Muslim majority countries. And despite being a particular risk, discussion of suicide within Islam is sometimes seen as taboo. So to respond to this concerning research and address suicide prevention among the community, Dr. Rania Awad and her colleagues at Stanford University School of Medicine created the Muslim Community Suicide Response Manual. And the manual pulls together evidence-based practices for reducing suicide and reinterprets them through an Islamic lens. The manual includes versions from the Quran, integrates the science on suicide with the ethical and moral understanding of suicide within the Muslim faith, and articulates as an Islamic mandate to intervene with those who are struggling within the Muslim faith, and articulates an and her team developed sermons informed by evidence-based practices that imams can take back to their communities, because imams acknowledge the value of this resource, noting that without the physical text in front of them, it would be more difficult to effectively address suicide in their community. And we can't forget about our minority faith traditions, very important, our minority faith conditions. I think we're not on the same slide. Let's see, let's go up one. I'm sorry, go up one. Go up another, please. We're definitely not on the same slide here. Okay, there we go. Now we're here. Thank you. I was having a hard time seeing the slides. Thank you so much. And so let's not forget about our minority faith traditions as we begin to think about how the research field can connect with leaders to set up efforts like the ones I have mentioned. It is also important to consider and engage minority faith traditions and groups in these efforts. It is important to consider communities that go beyond the groups you might first think about when you think about faith-based groups. For instance, it is interesting to consider the second largest religion tradition by state to better understand the religious diversity in a community in which a researcher is trying to engage faith communities. Based on data from the 2020 religious census, you might not know that the second largest religious tradition in South Dakota and South Carolina is the Baha'i faith tradition. In Montana and New Mexico, it is the Buddhist tradition. The second largest religious tradition in Nebraska is the Hindu religious tradition. So we share this to encourage researchers, not just to consider the first faith tradition that might come to mind in your community. In fact, when we work with these communities, we hear about how much they appreciate the engagement and having their voices be part of the conversation. This was our experience when we developed our public service announcements or PSAs on accessing help through 988 and the Suicide Prevention Lifeline. We worked with the Hindu American Foundation to develop a PSA engaging the voice of Hindu leaders to address suicide prevention and stigma around seeking crisis help. Having just one set of voices speak within their cultural tradition can increase connection and reduce intercultural pressure. We also created one with the African American community and the Muslim community. Some of these challenges can increase rather than decrease if audiences cannot connect. The speaker addressing what might be considered challenging subjects within certain communities. Research can consider the way they can engage diverse leaders, communities, and traditions as they consider connecting their work to the community. And while we do this work, because of the amazing work implemented in communities, we also know that this work makes a difference. For example, the Diabetes Prevention Program, or DPP, delivered in a community setting. DPP is a CDC certified program in which participants attend up to 16 weekly meetings with a lifestyle coach who trains them for long-term dietary change, increasing their physical activity, and to make the behavioral changes that will help to control their weight and to decrease their risk of getting type 2 diabetes. Through a pilot funded by CMS's CMMI between 2013 and 2015, the program outcomes were successful. Medicare beneficiaries enrolled in the program lost about 5% of their body weight, which is enough to substantially reduce the risk of future diabetes. The average weight loss was 4.73% of body weight for participants attending at least 4 weekly sessions. Participants who attended at least 9 weekly sessions lost an average of 5.1% of their body weight. In fact, when compared with similar beneficiaries not in the program, Medicare estimated savings of $2,650 for each enrollee in the diabetes prevention program over a 15-month period, more than enough to cover the cost of the program. And as a result of these changes, CMS expanded DPP to be included in the Medicare physician fee schedule proposed rule, allowing for Medicare funds to be used to support the program. So while DPP might be a widely published success story, what might be less well known is that the faith-based component of the story. This pilot was implemented by the YMCA, and you might not know, but the C in YMCA stands for Christian. YMCA stands for Young Men's Christian Association. In fact, many of the physical locations where DPP was implemented in this pilot were faith-based. So this story encourages us to consider that evidence-based models determined to be successful in the field can also find implementation within our faith communities. And this works best when there is alignment and interest with the community being served. But also consider a recent publication in the Journal of Medical Sciences where authors conducted a systemic review of 81 studies and 17,000 patients addressing cardiovascular disease risk factors. Common intervention types include addressing diet, physical activity, and stress management. And many of these strategies for addressing these interventions included educational classes, health coaching from community health workers, as well as inclusion of religious themes into intervention types. So across these studies, these church-based interventions were associated with significant reductions in risk factors for cardiovascular disease. Furthermore, the researchers note that these outcomes in these programs are achieved particularly in population with health disparities. Next. So if all of this works, and there are amazing partners with whom you all can engage, how do we engage them? So let's start with what not to do and get that out the way. Let me start with 3 things researchers should try to avoid. First, try not to tell leaders what they need or should care about. Know that faith leaders are very aware of what their community is concerned about. As researchers, you can ask them for insight into those concerns. Consider ways that you can help educate leaders on issues of concern and seek their input on how those concerns might relate to their community. Second, all faith leaders are not the same. Different traditions, different leaders, and different communities all have a diverse range of perspectives, ideas, and experiences. Researchers can be curious about these experiences and to learn with leaders about each community respectively. Note as well that even within one religious tradition, there may be a diverse range of views and perspectives about the issue you are seeking to address. So just because you may not be able to engage everyone in a community because of diverse viewpoints or perspectives, that should not keep you from engaging the faith communities and partners interested and willing to work with you as a researcher. And lastly, we have to be careful not to give faith leaders just another thing to do. One recent popular article among clergy highlighted how faith leaders, at least faith leaders in the Christian tradition, have at least 7 different jobs that in other circumstances could be considered full-times in and of themselves. In fact, these roles can be so overwhelming that there is a significant concern about the role of burnout in clergy leadership, as many are leading while bleeding. Consider strategies and efforts engaging faith communities that support rather than burden clergy leadership. So your engagement with the community can offer strategies that empower and support congregants to the house of worship. So rather than coming with an ask that puts something else on the leadership plate, come with an offer describing how your work can support their work in the community and their work with their congregants and provide resources. So if we're asking them to invest a significant amount of time, then we should also invest even with funds. Now let's consider 3 strategies to improve engagement with faith leaders. 3 strategies to improve engagement with faith partners, rather. First, let's start with listening. Consider opportunities to engage with the community before you reach out. It may be helpful and appropriate to visit the community in person for one of their events open to the public. Note that many houses of worship are also engaging their community through online resources. So check the community's YouTube channel and their website for ways to learn more about their community. Seek out friends or professional colleagues who identify with the religious traditions for advice on engaging a particular issue within that community. Then reach out to connect with the community. While engagement with their senior leadership will be important at some point, recognize that engagement starts with the person who answers the phones. So you might meet with someone who manages outreach for the congregation before you meet with the senior leadership. So when you meet with any level of leadership, care about the relationship more than the commitment to participate in the research. Know that faith leaders prioritize relationships and connections more than the research or scientific endeavor you're trying to engage them around. In fact, they're in the position they are in because they prioritize those community relationships. So putting relationships first is important to building a connection and relationship with these leaders. Second, seek to learn. Again, before you reach out, learn more about the community, the religious tradition, or issues that are important to that tradition and or people group. Determine if there are any efforts underway in that community that connect to the research issues that may be related to work you also have underway. So if you are focused on encouraging positive health behaviors, does the community promote any areas of physical activity such as softball league, pick up basketball games or exercise classes? If you are healthy eating, does the religious tradition say or prescribe anything related to what community eats? When you reach out to community, ask questions from a position of curiosity rather than prescription to better understand how their perspectives relate to that particular house of worship. Broadly stated, when you first connect, ask more questions than the number of answers you provide as a researcher. Ask more questions. Ask more questions. I'm going to say that again. Ask more questions than the number of answers you provide as a researcher. This can help ensure you're engaging leaders from a posture of learning with faith communities. So lastly, I want to encourage you to seek ways you can lead with faith communities rather than telling faith communities what and how to implement science-based, evidence-informed strategy. And level of communication is equally important. So work with the tradition and community to translate the science and research into the language, customs, and practices that already exist within the community. Engage the wisdom of the leadership in the community to connect to existing knowledge and wisdom from research literature. And next, in my last slide, just a few suggestions as we increasingly view, I'm going to skip over this, so I know we're at time. Let me conclude. As we move toward a time of questions, the last time we brought together actually in August of 2023, we brought together academic and research leaders at HHS. And when we did bring them together, they were surprised and energized as we shared models and strategies that connected religion and spirituality to mental health and well-being. And the purpose of this meeting was to bring together academic programs that prepared faith leaders for working in communities, mainly theological seminaries, including houses of worship, and how these institutions could increase attention on mental health and wellness during this critical time of training education. And that's mental health and wellness for staff, as well as for students. The meeting showcased the ways these academic programs were integrating mental health into their curriculum. This presented opportunity for these programs and their partners to engage in research about these programs and their outcomes. This research was helping not just to inform and strengthen these programs, it was considering the opportunities to support the growth and development of these clergy in training as well. The meeting also brought together federal funded programs that were building partnerships and engagement with faith communities around mental health and substance use programs. And these programs engaged diverse partners from tribal groups, rural groups, and urban clergy, to name a few. They described efforts from downstream, back up one, please, from downstream prevention efforts to intervention strategies for individuals affected by these challenges. And at the end of the day, as the group reflected on the presentations, one researcher noted that they had no idea about the work that could be implemented in this space. In fact, she was leaving energized, excited for the work that lied ahead and how federal entities and partners could be part of those efforts. At least in part, I wish that, and I hope that this presentation has gotten your imagination working and that you are interested in considering ways to connect your work and interest in religion and spirituality to the treasure that is our country's faith community. And being able to convene something with NIH, as we did with SAMHSA and this community, would be welcome. Again, the HSS Partnership Center can support these connections and can work with you throughout the year, or even think through technical assistance for faith communities that could best serve NIH and ultimately the administration's needs. So we encourage you to reach out to us. We stand ready to support increased research with and engagement of faith communities across the country. And thank you so much for the opportunity to present. And the last slide is basically some resources that we have readily available. As I mentioned, the maternal health guide will be coming out soon. So if you want to download that on your phone via the QR code that's listed, please feel free to do so at this time. We will also drop the links into the chat. And so that if you are not able to download the code itself, you will be able to copy the links from the chat. And then my last slide is let's just stay connected. Let's stay connected. Back to you, Joe.
And thank you, Reverend Q. That was fantastic. I'm always really amazed to hear all the wonderful work you're doing in so many different health areas and priority areas as well. I'm going to stop sharing so we can all see each other better and invite people to turn on their videos. I'm just starting to look in the chat here for what questions we have. Let's see. Okay. Okay, so there's a question here, Reverend Q. Is it Bives Matume? Sorry if I have mispronounced your name. I'm wondering why the priorities are mainly targeted the youth. What's the rationale of choosing that age group?
Okay, so that we actually, for mental health, we have a special emphasis with youth. If you think about it, the Surgeon General has declared a national emergency for youth mental health in 2021. We had an uptick of over 51% in emergency room visits, average age 12 to 17. We are seeing a major uptick of, as you heard, in our religious community, Muslim youth, unfortunately, leading the way there. We also seen an uptick of suicide in our African-American teenage boys. And so there is a reason for that special emphasis. And particularly when you have the Surgeon General declare a national emergency, that is something that we do focus on. So it is not the only thing we focus on in mental health in general. We speak to clergy, we speak to frontline responders. We have a special interest in helping frontline responders, particularly clergy who I had mentioned are leading while bleeding. And so when we think about the suicide prevention and the special emphasis on that, again, is when we think about the emergency room visits, right? They were based on suicidal ideations, right? And so, and attempts in this case. And so that is part of the reason why those particular two areas that we are doing adult and youth in those spaces. And then when you think about the work in our substance use disorder, while we've had an uptick in youth related substance use related deaths among youth, not just because the drug is so common or not because, it's increasing as far as the usage, but more so because it's so dangerous. And so there's a lot of work to be done with our youth population.
Thank you, Reverend Q. Next question I see, David from Indian Health Service. Which HHS offices or office organizes the collaboration between institutional research, for example, NIH, and applied health policy and system research, for example, Indian Health Service, when there are community and agency needs to study comparative and specific efficacy and effects of congregation and healthcare cooperation, such as local referrals, co-managed services, case coordination tool, data, and communication integration. David, maybe if you want to provide a little bit more on your question. Thanks.
Yeah, hi, and Dr. English, thank you for your presentation. I appreciate that. Good job. Yeah, I mean, it's interesting. At Indian Health Service, we're working with, over 500 sovereign tribes, and all those communities are diverse in themselves, and there's no simple answer, but there's a huge appreciation and push for questions of spiritual health development, working with congregations, coaching through chaplains and such. But when it comes to evaluating the needs and thinking of it more scientifically, where we try to figure out what's applicable to the system itself and to the tribes who are negotiating with the system, it would be helpful for us to know, how does HHS offices, your office or other offices, create this coordination between Indian Health Service, where we're kind of heads down trying to focus on all our tribal constituents, and NIH, which is doing more institutional research with universities and other bodies. So it seems like, I appreciate everything you said, but it seems like there needs to be like one more step in the coordination process, so that there is a I think NIH would call it something like translational research, where it becomes more applicable to the systems they're delivering services.
That's a very, very good point, and thank you for flagging that, David. One of the things that we're doing right now is we're working with IHS on some of the movements, to your point, because for us, it's education for us, right? It's like we can't, as I mentioned earlier, there's such diversity around our nation that there's sensitivities, there's cultural competency, there's cultural and sensitivity that needs to be considered. So, even when it comes to our maternal health tour that we're doing, we are targeting tribal, like in 2024, we're going to be on some of their land and sacred land, spaces, and the need for us to be educated is critical. So we are working with IHS, and we're working with ACF in their tribal spaces, and working with the person that leads our tribal efforts at IEA, all of us collaborating together to see how we can be more effective to your point, in the conversation, the penetration, and it has to be led by a trusted messenger of those communities. We can't just, and just because we're HSS, and just because, I'm Reverend Doctor, we can't just show up, right? I have to have someone that's a trusted messenger in that space to open that door, and then start creating opportunities of dialogue to see what approach works best, and how do we, bring these resources and continue the collaboration in this area. So to your point, those are the conversations we started having with IHS in 2023.
Thank you.
Yeah.
Thank you for the question, and Reverend Q for the answer. I have a question here. What are some of the benefits of conducting research with faith-based partners?
I think, if we just look at the fact that they are the trusted communities they are the trusted messengers in community. It's one thing to hang out with these. A lot of times we first think of these mega organizations, right, to do the best work. But it's another thing to think about the kind of traction that you can get with those that are already in community, already has the pulse of the community, already know, what's going on. I just remember in some of the work that I did in New York, when it came to, criminal justice reform, I guess you can't really put justice in criminal, but human justice reform. We went, and government tagged those that were already doing the work on the ground. Who are some of those entities? And a lot of times we have this misconception that we don't have a lot of faith communities, doing work in the health space, or doing work in the space that, we are targeting it. But you would be so surprised about how many faith leaders and communities and entities are doing work in this space. And many of them are doing it because they feel it's what they call, quote unquote, their call, right? And so they're doing it without funding. And so for me, I feel it's critical for us to think about ways to engage them more. And when I say trusted messengers, that means you can fund someone else to do the research, and they're trying to get a focus group together, and they can't get more than 2 at a table, but you get a trusted messenger out there who the community will gravitate toward because they trust their voice. They trust that if they're going to invite them to the table, that there is a reason, and that they will come, because sometimes they're not going to come because we have .gov, right? But they will come if it's someone from their community to these types of convening. And so for my success, even in doing the work in human trafficking and domestic violence in New York City, I intentionally created it where I led the convening as a community leader and invited government to the table. So we ended up walking side by side, but I was able to get every single service provider that had anything to do with human trafficking to that table, and together collaboratively we're able to create the focus that was needed on human trafficking in New York, and creating an office that focused on that, or or a part of existing office that focused on that, and get $1 million into the budget to address that. But my point is saying that is, it is important that researchers find ways. And again, we're here to support you. That's why we're here. The Partnership Center, we are here to support you. We're here to help you navigate those waters. We're here to help facilitate introductions and perhaps have conversations the way we did in August, with the academic community. That was really, really helpful for as SAMHSA, was involved in that as well. And so let's think about ways we can move ahead, with those types of partnerships. And there's challenges, right? The challenges are going to be, the fact that, community doesn't necessarily trust government. Those are one challenge, right? And the motive behind it. And with a lot of the funding stream that passes over them, and this is a challenge, right? It goes to an entity, and then the entity creates these faith communities as sub-grantee, giving them pennies on things that they are now running with, but yet they were able to get the full funding for. And so being able to switch up those dynamics, I think, is critical as well. And then there's challenges, just based on all the other things that are going on in our world. What are our priorities? So we have to be strategic and efficient in identifying, what to target, where to target, etc. So I'll stop there. So just in case there are other questions. Sorry, Joan, I went a little bit longer
No,
than that.
thank you. No, it's all good stuff. It looks like there's a question from Alicia. Did you want to ask your question about during the COVID pandemic? I'm not sure.
Yeah,
Go
I
ahead.
can. Wonderful presentation, Dr. English. I was just interested, as you know, there was a massive push when Dr. Fauci was the NIAID director toward trying to reach faith-based communities, especially at the beginning of COVID. During the pandemic, when things are, quite serious. And I was just wondering if you thought NIH had placed more emphasis, as you spoke upon the importance of building community relationships before advancing their own agenda. And if you thought that they were successful in doing that, or was the vaccine agenda more pushed per se during that time, during that crisis, as NIH was going about trying to reach other faith-based communities? Because they, of course, the stigma of certain communities that didn't trust, science, right? Because of experimentation, Tuskegee, and so forth, things like that. And so, it was a hard time to encourage other ethnicities and so forth, right, to take the vaccine. And I was just curious on your thoughts about that.
I'm not too familiar with what NIH did specifically during that time. But what I am familiar is that we have like stellar examples in the faith community that rolled up their sleeve, and because of their efforts, people received the vaccination. At the time, I was working with the governor's office of faith-based neighborhood initiatives as deputy director there. And we saw an increase. Like, there were some stellar groups like Choose Healthy Life. They specifically focused on the African American community, and was, hailed as bringing, vaccinating some of the highest amount. I'm trying to get the numbers for CHL, but it was Choose Healthy Life, led by Deborah Frazier, who was also used to be on the front end of combating HIV/AIDS back in the day. But they were credited for having some of the largest vaccination rate among African American throughout our nation. And so, and again, that was due to, being trusted messenger. And obviously, Alicia, that in the very beginning, we were faced with all of the false information and skepticism and being compared to Tuskegee and all of that. But it took the trusted community to step up to the plate to engage. And so what I saw was houses of worship everywhere, just popping up and just saying yes and rolling up their sleeve and becoming sites for vaccination. So I'm not clear. I mean, if you want to elaborate more on the messaging by NIH, but the faith community had to be the buffer between government and the community in order for us to even realize the vaccination rate improve. And one of the things that happened in New York, there was grants giving to the faith community specifically, only to the faith community. They were looking for the faith-based entities to move in this space because of the challenge they were having in convincing our underserved communities, whether they were Black, Brown, just across the board, the importance of being vaccinated.
Yeah, thank you very much. I think that a lot of what you just said was kind of missing in that piece when that time, so researchers would kind of know what was going on behind the scenes with such, impactful resources that were becoming available, and people were hunking down to try to reach those different types of communities and faiths and so forth. So thank you so much. I appreciate that.
Absolutely. And thank you for that question, because during that season, we were really dealing with a lot of hesitancies. We even facilitated, meetings where, doctors would come on, and doctors that looked like us, right? So that's why I also think about what is that cultural competency, sensitivity, and how do we show up, right? How does NIH show up in that space when we think about culture? Case in point, and this is, true. What really happened, I went to Buffalo during that TOPS incident where we had so many senseless, that the killing that took place, the murders that took place at TOPS Market. And I had visited several times along with some of my other colleagues from the other centers, but I visited several times on my own. And one of the first things that we all heard, and it was reported, and that is, can you please, particularly in the mental health space, they said, can you please send someone that looked like us? And so my point in saying that is that however we move, that we embrace cultural sensitivity, cultural humility, cultural competency, whether it's African American, American Indian, Alaska Native, as my conversation just with the gentleman that asked a question earlier, whether it's with the Hispanic population, whether it's with these diverse religious communities, knowing what to do, knowing what to say, and it's all of that plays into whether we're going to be successful or just very successful, or partly successful, or not successful at all. So we have to consider all of those dynamics when we approach, the faith community as well as other communities.
Such important information, Reverend Q.
Mm.
Other
Yeah.
questions? We have time for a couple more questions or comments for Reverend Q.
And I did want to say,
Joan,
go ahead.
sorry, Joan, I just want to comment. This was excellent. Thank you very much. And your point about cultural competence and not only knowing it, being aware of it, but I think all of us really, that's the biggest take home message here.
Hmm.
Because that's the only way we can really get across to such a diverse country.
Yeah, you're absolutely right, Anne. And, and to your point, even as a religious leader, a religious leader myself, I remember, at a certain time, it's like, we're only invited to do the benediction and the invocation, and and I think an important ingredient, and I think was missing even in my journey, is being at the table to contribute, to be a contributing voice. And we were able to break through that, and we ended up being at the table more. But I think that's important, right? Even in the brainstorming, thinking about faith leaders that have interest in this space for an NIH particularly, and what your focus is. Who are those leaders that are on the ground that can help influence how you move in that space before you leave the four walls, before you leave your office, thinking about, who do you need to bring to the table to help formulate, to help draft, what you desire to do, versus then, here is something, I want you to kiss it and bless it, right? That's a different approach than respecting them not only as faith leaders, but not only as trusted messengers, but the potential wealth of knowledge they can bring in the space that you're interested in the subject matter that you're interested in. I think that's another important conversation. How do we get them to the table ahead of time? And thus making our outreach efforts even more effective as a result of that.
As well as being aware that in each group, in each culture, there is a very diverse group.
Yes.
And when people come from different countries, you're going to see more diversity.
Yeah. Yeah, you're
Um,
absolutely right.
So, like, especially working with patients, we had a few examples of people who came from countries like Peru. And on our hospital forms, they would put down, when asked their religion, they would put down Catholic. But when they started having a lot of spiritual inks, it was discovered that, yes, they were Catholic, but they also had beliefs where they had shamans as faith leaders and cultural spiritual leaders. And a lot of their spiritual inks actually came from that whole part of their faith and culture. So it's really being acutely aware.
Acutely aware. There is that, and to your point, we're talking now about religious competency and sensitivity as well. And so thank you, Anne, for sharing that.
Now, so the office is more of a tie between all the HHS, like NIH and SAMHSA, and so is it less focused on research and more on putting together these educational toolboxes, or?
So we're focused on anything and everything. So if you, what we do is connect you. We're like, just think of us as your liaison to the faith and community, our faith and community stakeholders. And we're not just work with FBOs, faith organization. We also have strong relationships with CBOs, community-based organizations. So we provide support to them, connected them to the resources that exist within HSS and even resources that exist outside of HSS. And so to answer your questions, it's all of the above.
Okay.
Thank you. I see Deirdre has her hand raised, and maybe that will be our last question. Deirdre, do you want to go ahead?
I just want to start by thanking you, Dr. English, for an outstanding presentation. I am so excited about the prospects for building relationships with the communities. And the principle I want to underscore most of all is the importance of maintaining these relationships, is starting them and staying there. We need to be a constant presence in our
Yeah.
communities and not just run to communities in times of crisis. And
Yes.
after all, that's why most of us exist, is, for community service. So I just want to do all that we, help us in our efforts to maintain these relationships over time. And thank
That's
you.
I love that idea. I'm so glad you brought that up, Deidre, because I'm sorry I cut you off. Please continue. I was going to
No, I'm done.
Okay, I was just going to say, because the faith community, we're relational, not transactional,
Yes.
right? We're relational. We're about transformation. That's at the top of the faith community's head. So if we start sensing transactional, it's a little less inviting or engaging, or it's sort of like semi closes the door, even though there are places where we are strictly, we have to create that transaction. However, think of faith community as being relational and transform and focus as an entity that focuses on transformation. So with those two things in mind, make sure that transaction is at the bottom of the list.
Thank you.
Thank you.
Okay.
Thank you. Well, again, what a fantastic presentation, and thank you so much, Reverend Q. I know Deirdre and I and others have worked with you on things, and and your staff, and it's just been so helpful for us in our efforts. And I just can't speak highly enough of the work that you and your team is doing, and we just hope to continue collaborative efforts with you. I know I enjoyed this presentation. I hope others did as well. And I hope people learned more about the important work that Reverend Q and her staff are doing, and how you can collaborate with them and brainstorm with them and get ideas from them, and share your ideas with them, so that we can all, do better.
Thank you. Can I acknowledge too that on this call is one of my staff persons, and Ben Odell, that's worked with me closely on getting this presentation ready. But Ben Odell, who has been with the Partnership Center for many, many, many years, he's also has joined us on this call and will be instrumental as we think about what we want to do together and moving forward. And yes, Alicia would love to come back at another time, but I do have a 3 o'clock with the White House, so I do have to jump. But thank you so much.
Thank you. And thank you, Ben, and thank you,
Thanks.
everyone, and have a great rest of the day. Take care. Stay
Take
safe
care.
out
Thank
there.
you, Joan.
Thank
Thank
you.
you,
Thank
Dr.
you.
English.
Yes,
Bye-bye.
thank you.
Bye-bye.
Yes.